Hello and welcome to PCR webinar, New Tools and Technologies in the Treatment of Coronary Bifurcations. Welcome to Bifurcation Continuum 2024. And you know, at absolutely every bifurcation session, at every meeting, the first question is how to use drug-coated balloon. Can we use drug-coated balloon? Can we use it for the side branch, or we don't need stents at all? So today we decided to discuss with you real-life cases. And first case will cover drug-coated balloon use in treatment of complex coronary bifurcation. We'll discuss together the evidence base for use of drug-coated balloons, and we'll discuss how to prepare the vessel, how to deliver therapy, and evaluate the immediate result after DCB use in complex bifurcation. Then we will have a glimpse into the future, and we will discuss new technology. We will try to learn when and how to use angiography-based physiology to plan the strategy and to optimize the result of bifurcation PCI. My name is Goran Stankovic, and I have great colleagues and friends with me, Dr. Stefan Fournier from Lausanne, Switzerland, and Dr. Manuel Pan from Cordoba, Spain. Please use the chat. Each time we are really happy to answer absolutely any question or comment you may have. So I would like to invite now my colleague and friend, Manolo, to present his case. Manuel, please.
Thank you, Goran. It's a pleasure to be here in this interesting question. And our case is a man, is a male of 71 years, hypertensive, diabetic, with symptoms of a stable angina in functional class 3, with a prior PCI where 2 drug-eluting stents were implanted at the circumflex 2 years before. The current ECG showed no significant findings. The transesophageal echo demonstrated a preserved left ventricular ejection fraction, and the angio showed a distal left main calcified bifurcation lesion. In this slide, you can see the coronary angiography 2 years before. We performed at the LAD and physiological study with IFR that was in the limit, but with no accumulation of points. So we decided not to treat the LAD. We treat the circumflex that demonstrate a severe lesion that received 2 drug-eluting stents. The current angiography is showed in the screen. Yeah. You can see the 2 orthogonal projection, and we also prepare.
Yeah, Manolo, let's join us at the smart screen.
Yeah.
So we can discuss the basics, what EBC describes, distribution of plaque, how to plan the strategy. On the left-hand side is a still frame, spider view. And if you can explain your view, when you see this one, it's definitely complex. But how would you describe to colleagues bifurcation here?
Yeah. Well, we can first the contour, no? The contour of the vessels. The left main to the LAD is over here. And now we can annotate the distribution of the plaque in yellow.
Beautiful. So we know that plaque is usually in the lateral wall, yes, opposite to the ostium of carina. So carina is usually completely spared from calcium. So this is actually what we see on this angiography.
It's a little
beautiful.
This is not a complete occlusion. It's very severe.
Yeah, but it's very severe lesion. And if we really discuss the strategy, we always need to keep in mind vessel contour and then plaque distribution, plaque composition. Based on that, we actually decide how to do treatment with stents, with balloons, or whatever. For me, it's really very complex. I like that circumflex is a large vessel. Diameter of the circ is really big. And I like your drawing here. This is actually the plaque from the left main entering in the proximal part of the circ. And circ is big. So I agree with you, 1-1-1. Maybe we can discuss and we can invite also our attendees how they would treat this lesion. You posted this on X or on Twitter.
Yeah.
I enjoyed very much, a lot of comments, a lot of good suggestions. To start with the first question, this is complex patient with complex anatomy. Did you discuss it with surgeon? Did you have a heart team discussion?
Yes.
Because several colleagues recommended CABG.
Yes, yes. We discussed the case and we also obtained the syntax score. The syntax score is less than 22 and seems to be the limit to decide between surgery or PCI, because in this kind of patients, the recommendation is similar. It's
lower,
1A.
Yes,
so
lower anatomical complexity. And what was the decision of the patient? We tried to include the patient in decision making.
No, the decision of the patient was that preferred the percutaneous approach.
Okay, thank you. I think this is relevant for colleagues who responded to your message. And let's now discuss between three of us how would we treat before you show us. I'm really interested, where is the application of DCB, in which direction, for which branch, very calcified, should we prepare the lesion, and how? Stefan, this is your patient. What would you do? What is the strategy if you have to treat this patient?
Well, it is indeed a complex case. We are dealing with a very calcified left main. It's a very severe stenosis involving true bifurcation. We have to remember that 2 years ago, the IFR in the LAD was not significant. It will be a surprise if it was only calcium to see that fast a change. So probably there is calcium, but there might be also some acute setting also in this plaque. Here, I will have, I think, a low threshold to open a rotablator. In my experience, when you have it in mind, if you don't open it very early, you are just losing time, because anyway, you will open it at a moment or another one. I think we have also to use imaging in this case, but I'm not sure if we can use it from the beginning, given the severity of the stenosis. For the questions, 2 stents or 1 stent strategy here, I think the imaging is important to help us to guide, but I think one approach will be to go for a classical 2 stents technique.
What would be your strategy? I mean, of course, you individually decide. It's individual decision for specific patient with specific comorbidities and specific distribution of the plaque. This is, look the size of this circ. It's really super big vessel, so we need to really, whatever strategy we plan, we need to take into account a lot of calcium plus the size of the circ. I'm disappointed so far there is only one DK crush. Usually by this time we have 10 suggestions of different strategies, so please be more active. I hope somebody will say provisional, so that will really open the floor for discussion. And what did you say? What would be your 2-stent strategy?
Well, I think I will start with the rotablation, do the imaging, and if it's a 2-stent technique, I will go for a DK crush.
DK crush. So rota first, and then Manolo, you know my strategy is always the same. So I don't have, I think that stepwise provisional, following the recommendation of EBC and postponing decision about stent placement until throughout the procedure. It's actually progression of steps. I don't think we need to decide upfront unless you start with DK crush, that I agree. DK crush, stenting of the ostium of the LAD, probably in this case because of superdominant circ. But for all other strategies, provisional stepwise, do 1 stent, do optimization, pot, discuss whether you need KISS. After KISS, you evaluate the result, you use imaging, you check, and then you see if you need 2nd stent, you go for 2nd stent. So you don't need to limit yourself to discuss from the beginning just 2-stent strategy. Do you agree with me, Manolo? What are the questions you discussed with your team?
Yes.
Maybe you go to the next slide. You have a nice summary. Yeah.
Here you can see all these questions.
Yes.
And the first one is the strategy, the provisional versus dual. Within the provisional, we have the classical, the stent at the main vessel and kissing and see what happened, as Goran mentioned. But we have also a possibility that is include the DCB. The DCB can be included to treat the side branch and the side and continue with the same philosophy that is recommended by the EBC. So
exactly.
It's important.
There is a question. I like to read these comments because we do this for these friends. I have so many friends, and you said there are many followers, but followers are people with whom you really have the opportunity to discuss and exchange.
Yeah.
And Kritom Ioannis Rukas is asking, please, rota or orbital and why? Yeah. Manolo, you are the expert for lesion preparation.
We will see the
See.
answer.
So
we will see the answer in the next slides.
But in general, what is the difference in indication in your experience? When would you use orbital instead of rota?
Yeah, but it depends mainly of the availability of the device in your hospital. Because so if you have all the tools, you can select the correct one. But in our hospital, we have not the IVL. It's not in Andalusia, so it's not. So we have only the rotor. The rotor and lasers are the only.
So only in Andalusia, not in Spain, because I've seen cases from Madrid, from Javier, with fantastic application in very calcified distal left main. He did the live case with IVL, and this was really fantastic. I like very much the cases with him and with Nives. Each time I learn so much how to actually use the imaging to make decisions. It's not just I did IVUS. It's I do it, I find this, I interpret like this.
But
and I respect really...
Also we have the non-compliant balloon, that is the cheapest technology and effective
there is good,
also, and the OPN.
There is good suggestion also, Lorenzo, to a very simple rota, IVUS, DK. I hope DK culot, maybe not DK crash. DK crash, probably. It's probably DK crash, I'm joking. And there was another one, now I cannot find it, but should you rotablate in the main vessel only, or should you rotablate in both main vessel and the side branch? You said you did imaging to decide. So let's don't keep people without that information. Please go on.
Okay, thank you.
And let's see.
Let's see. First, we obtained image. In this case, it was an IVUS. In the slide, you can see the pull back from the LAD to left main, and we have also a summary.
Yeah, I think
on the right, with the chroma flow that being clarified a little bit the lumen, and on the left without chroma flow. This is a technology from Volcano. And you can see that.
I think it's very important to understand what we see on IVUS, and then it's not just I did IVUS. Actually, when you do IVUS, it needs to help you make decision or change the initial decision. So what we see here, and thank you very much for this nice sketch here. So we see combination, it's mixed plaque. Please explain what you prepared already in advance.
Probably in calcified plaque, you need to know
you come a little bit closer, and you just show us.
You need to know the distribution of the calcium. The calcium is marked by the white arrows.
Yes.
You can see an important information. The calcium is not circular.
Yes.
We have not a ring of calcium.
This is also what Stefan expected when he said in 2 years, likelihood of having it's really very low.
It's a mix of a soft plaque in yellow.
Yeah, so it's this part here.
Appear in the counter carina. This is the origin of the circumflex.
Circ is this area here. We have some calcium also here. And actually, this is the arc of calcium. Plus some soft tissue.
Here. In the longitudinal, representation, you also can see the circumflex. So,
if I can summarize, it's less difficult than we expected based on angio. Okay, let's go back to the slides. now I'm looking forward to strategy.
And another important detail is that the IBUS didn't cross to the circumflex artery. We also, in the presentation, the presenter show us excellent and beautiful image of calcium, but sometimes if the calcification is important, you have not a baseline image. So it's important.
I think it's an important question, although you said that you don't have IVL, but Juan Ignacio is asking, would you use IVL in left main with dominant circumflex, considering that you need prolonged inflation of IVL?
Yeah, we have not IVL, but probably you can try.
Yeah,
you can try if the patient does not tolerate the inflation. You can deflate.
You applied certain amount of pulses, then you let it breathe, and then you continue.
Yeah, but sometimes the IVL does not cross. Because
in this case,
cross with the IVS, you will not cross with the IVL for sure.
Yeah, I remember Dr. Colombo, but this was 20 years ago. He taught me if you want to assess lesion, you don't need console, just the catheter. If IVUS catheter does not cross, it's significant for sure.
Yeah.
So in your case, we know it's tight. Rule. But let's see, you decided to predilate? What was the decision?
Yes.
Now we know there is no really circumferential calcium, and the amount of calcified tissue is less than we expected. So you started with NC balloon or cutting, scoring?
Yeah, with NC balloon. But another point is we have not information about the circumflex. Okay. So we have to start the procedure without a complete information about the distribution of the calcium in the bifurcation.
Let's see.
Now you can
These
see
are the technologies
all
we already
the technology.
Touched. Yeah, we already touched
in our hospital, we have the high pressure balloon, the OPN, the scoring and cutting balloon, and the rotablator and laser. We are going to introduce the orbital, but for the moment we have not experience with this device.
So your choice was high pressure?
Yeah, because it's the cheaper and the
cheapest
simple.
one?
Cheapest and the more simple.
And inside the left main you saw that it's not really circumferential, so the likelihood of achieving good result is higher than expected. Let's go to the case.
Yes. In this slide, you can see the use of the non-compliant balloon, first with 2.5 millimeters and then 3 non-compliant balloon millimeters at the LAD. And for the circumflex, we start with 2.5 non-compliant balloon, and finally we dilate with 3.5 millimeters in order to obtain a good lumen and to pass the IBUS catheter and obtain the
this
important
is exactly
information.
Exactly what Mohamed Wakas Mazar was suggesting: imaging, cutting balloon, re-imaging, and then decide the strategy. Bravo, thank you. Does thickness and length of calcium is important? I guess the question is at what point the arc of calcium changes your strategy toward
the more you have, the more rotablator you use. So the circular,
if it's less than one,
for a circular calcium is an absolute indication of rotablation or
if it's
or
less than
orbital
270. Less than 270, you may consider balloons. If it's more, then you do it. Okay. Let's see if we have more questions. So go back to the case, and
now we can.
Now you are able to go with the IBUS catheter into the
circumflex. The circumflex is a bigger vessel, as you mentioned previously. It's important in order to decide who is the mother and who is the daughter. And also, it's the more diffuse calcium inside of it. On the right of the slide, you can see different part that has been represented in the longitudinal representation. Number one, you can see calcium, but again, it's not circumferential. So it seems to be superficial calcium, some nodules of calcium, and also an important detail is that the lumen is good. So we obtain a good lumen with the 3.5 non-compliant balloon. that allows the crossing of the IBUS catheter, and also we did not observe we observed a good expansion of the balloon. So this is another interesting data of the behavior of the calcium.
You actually evaluate circumferential versus
nodule or
and then you focal. And then after predilatation, you actually evaluate the cracks that are indicators that you may fully expand the stent afterwards. And of course, you would like to check if there is dissection, or so you can plan the strategy. I think this is very important question. Okay, you did not need to use rota, but William Camilleri is asking, how do you size your rotablator? So you start with 1.5, or sometimes you go progressively.
It depends also of the guiding catheter that you have. In this case, we have a 6 French.
Okay.
The 6 French allows a maximum burr of 1.5. That probably would be the selected burr in this case. But for a big vessel like the circumflex, probably you need a bigger burr.
Yeah. Tell me regarding the strategy, if you saw the angio with such large amount, big vessels, large amount of calcium, you still decided to do 6 French.
Yeah.
You don't use 7? Just
probably it
more
would be better
internal,
the 7. The 7
internal
would be better.
lumen, you can go with 2 NC balloons in the same time and have simply much less friction inside the guiding catheter.
Also, another important detail with the use of rotablator it depends of the size of the vessel. In a consensus, you have a table. We have the table in the lab. I consult the table because from memory, it's very difficult. So, but I think this vessel would admit a bigger burr.
Bigger, yeah. Dr. Cavaya is asking again. Calcium, you evaluate circumferential nature, but you also evaluate thickness and length.
Yes.
Are there some criteria that you predefined regarding the thickness of calcium, how it changes your strategy?
Yeah, so the more calcium, the more aggressive you
need to be in preparation. Yeah. Stefan, would you add something on this? You agree with?
No, I think the strategy is really fine. Now we have much more information as compared to the beginning regarding the circ, and we can go on with the procedure. And I look forward to see what you did.
Yeah. Okay.
Also, a concept that can appear in some consensus is the nodule is better treated by orbital atherectomy instead of a rotablator. Yes. And for superficial calcium, it's better rotablator. But I think sometimes it's difficult to differentiate.
It should be individually assessed, and as you said, depends also on the available material.
Yeah.
Let's go to strategy. I'm really interested to see the strategy because I have my idea, inverted provisional, and then see. But I would like to see what was your selection.
Yeah. You are right. Again, before to discover the strategy, we have the same question, but with more information. Now you have information, and now you have the behavior of the balloon. The balloon has been well expanded.
Fully expanded.
So you have this, and we have we repeat the same question, but you have summary. So
Manolo, is it mistake if we decide now to do decay crush?
Yeah.
I think who knows how to do it in expert hands. Decay crush is also good in this case. No lot of calcium, good expansion of the balloon.
Yeah.
So you really, honestly, although I'm provisional, I like the fact that with decay crush you maintain the wire in the main vessel throughout the procedure. So for complex anatomy, I really think that this is important advantage, in addition to some study results. So it's not mistake. People who suggest here decay crush in distal 1-1-1 left main is good decision. So it's not wrong.
Yeah.
We believe that we can do it progressively, starting with less metal and then finish with 2 stents if we need, or we use DCB. I think let's go to the first part, show us the stenting.
Okay. Well, I think like you, because this concept has been discussed a lot in the ABC, and we have the ABC main with the result that the provisional is better than DK crash.
I think it's important.
Mainly in short lesion of the side branch.
Yeah, I think it's important because we have our participants who are in favor of DK crash and those in favor of provisional, but I believe that everybody is right. It's a continuum. So for shorter lesions, like 7 millimeters average in EBC main, we have fantastic results with provisional. We have very good clinical outcome up to 3 years, and I'm really looking forward to 5-year outcome. At 3 years, we already have significantly less repeat revascularization with provisional versus DK crash. But in complex lesion like DK crash 5 with 16 millimeter mean lesion length, I believe that 2-stent strategy up front is good choice. And there is advantage, and there are several meta-analyses, Di Gioia, now Brugaletta group that we published together last year in Eurointervention. We really showed that 10 or 11 millimeter is the cutoff at which you see the benefit of 2 stents. So the longer the lesion in the side branch, the higher the benefit of planned 2-stent strategy. So I agree, DK crash is good choice also in this case.
So, what we did was provisional as suspected. We implant a first stent from the left main to the circumflex according with the disease of the circumflex and according with the size of the vessel. So it was an easy decision. When the size and the disease are discordant, it's not so easy, but in this case, no doubt about the stent across the LAD.
Okay.
Then we perform the POT according with the EBC recommendation and according with the IBUS information of the size of the proximal main. We repeat POT. I am going to show you why. And finally, we perform a kissing inflation. Again, the balloon of the circumflex is a little bit long but sometimes in the lab you have not the size, the length, and everything. So, but the recommendation is short.
Yeah, these are real life cases.
And short.
Yeah, we are showing live cases, and sometimes you have limitations.
Okay. If you have here the reason to repeat the POT. We select the balloon according with the baseline measurement of the proximal left main, but we check the position and the expansion from the circumflex to the left main. This is a pullback with chroma flow, as can you see in the slide. This is the less expanded zone, but with a good area after the POT and after the kissing. And now, in the more proximal part of the main, you have the detail that a non-apposition has been observed.
Yeah, you can just say it. I will show it. So we clearly see on the pullback not opposed struts. Especially this is the proximal edge actually, so that's clearly the reason why you decided to take bigger balloon.
Yes, this is sometimes this occurs. So it's important. The image at this point is important because although you follow all the rules of the EBC, the size, everything. Sometimes short balloons are not in from the carina to the origin of the stent. You not cover all the.
I like to take
and in this and at this time probably the size of the vessel is bigger than 4.5.
You know, this is, I need to make this point. I think it's very important. The role of imaging really help us see this and size appropriately balloon for the final pot. And also, with imaging, we can detect longitudinal stent deformation. And it's repetitive. You remember first in the Excel, they show 6.7% of longitudinal deformation, and then they show correlation with clinical adverse events at 3 years to follow up.
Yeah.
October also shows the same, and it's significantly higher the prevalence in ostial left main stenting detected by imaging that was not recognized by the operator. So imaging has really open indication in the future. We need probably to learn more how to appropriately use this, but definitely provides important information that optimize the result and improve clinical outcome. Yeah. So let's see what you have done after this.
I agree with you totally, and I think it's an important recommendation when you use image is that the last maneuver of the procedure is a pullback.
Exactly.
Because the manipulation of the guiding catheter trying to pass material into the bifurcation may produce the deformation.
Manolo, there are several questions related to which is the main vessel, which is the side branch. If you decide, for example, Adeogo Olusan is asking, if you decide on DK crush or provisional, what vessel do you use as your main vessel, LAD or superdominant circ?
I think that the main vessel is the same, it's the circ. So you have to follow the DK crush rules according with the main vessel.
So you crush the stent from the LAD and you use as the main vessel circ.
Okay.
Shakir Khan is asking how to decide to do the first stenting of left main to LAD, left main to circ. In this case, I think this is the answer. We have some compliments. Thank you very much. We do this for you and together with you. Bogdan Janusz is asking, I suppose, the stent from left main ostium. Yes, and we showed the malapposition at the ostium. Should we always protrude into the aorta? No, we try to cover the ostium without protrusion.
Yeah. In the longitudinal reconstruction, you can see that the stent is over here. So.
Exactly. Okay. Manolo, let's see the result.
Yeah.
And now, small dissection at LAD. Should we go for the second stent? Now we are at the moment of truth has come. Stefano.
Yes, we are. Well, I agree that the circ is very large. It's the dominant vessel, but still the LAD is the LAD and is giving a lot of branches. I think it will not be totally wrong to consider a stent implantation here, even if I agree that there might be other strategies. But I think a second stent to make it safe.
Okay, I think you are not alone. Many people would consider it's ostium of the LAD. Manolo, what you decide?
We perform image
Bravo.
to the decision. Now you have a pullback from the LAD. After the kissing was easy to cross into the LAD through the stent of the left main. You can see a good result of the balloon. But the dissection can be
maybe
seen,
we can show it here on the angio.
This is the angio, but I think it's in the screen, in the right part of the screen.
Oh, okay.
The arrows mark probably the dissection that seems to be, from an IBUS point of view, not very complex.
Yes.
So we have to admit if you dilate a vessel without a stent, some degree of
let's see
dissection.
what you decided and what you did.
We decide to...
okay. So DCB.
DCB.
Yeah. How do you select the...
Well, DCB is a new strategy that we discussed in the last EBC with different point of view. There is no agreement how to deliver the drug into the side branch. In this case, we decide to dilate from an isolated point of view the LAD with the drug-coated balloon, as you can see in the left part of the slide, but with the balloon located at the circumflex in order to perform the second part that is it is a kissing.
Okay.
So I think people that use drug coating balloon don't like to manipulate the dilated segment after the delivery of the drug.
Okay.
So in this case, we deliver the drug, we deflate, we remove the balloon from the circumflex, perform a kissing with the same balloon of the coated balloon, and finish the procedure.
If I understand correctly, and I would like to summarize for our colleagues, so DCB is not used to predilate. We need to predilate, prepare the lesion well. DCB is used to deliver drug.
Yeah.
And of course, any inflation through the stent struts creates metallic shift of carina, and compromises the main vessel, in this case circumflex. So if you do provisional with DCB in the side branch, in this case LAD, you need to finalize with kissing. Since we have DCB positioned at the ostium of the LAD, you selected NC balloon, and you can of course select also semi-compliant. It's a stented segment, it's a big circumflex, but the idea is not to manipulate balloon which delivers drug. You deliver drug in 1 minute, and after that you just pull back, position, overlap two markers proximally, and you perform traditional way of kissing. And next image, what you have on the next one?
This is the final angiographic result. The dissection is more evident.
Yes.
And again, you can be not happy with the result. And for clarify this point, we show an old slide that this is the classification of the dissection from the era of the balloon without the stent.
Yeah.
This is a very old slide, but it's very useful because at this era we have only balloons, so the dissection was carefully studied and analyzed.
Exactly. So just again as clarification, most contemporary trials with DCB as a cutoff to consider stenting is type C or more of dissection.
Yes.
And we discussed together, and we agreed that according to NHLBI classification, this is type B. So borderline, with your experience, I think you have really one of the largest experiences in Europe with treatment of bifurcations, you decided to leave it alone.
Yes.
Stefan, if I go back to you, you were considering possible stent also before, so would you change your mind or leave this or stent it?
I think, of course, one of the key elements, and you showed it very nicely, is the imaging. And after the IVUS that you did in the LAD, it's true that we are a little bit more confident with the dissection, which looks acceptable, I think. Yeah. Are there any cases where you check the patient again a few weeks after or a few months again when you leave behind you dissection?
We include this technology after our last discussion at EBC that we are planning a trial, and we need the experience with this new strategy. Well, all strategy, but new use.
Yeah, unfortunately, available evidence so far is really either neutral or negative. We don't really have positive studies so far. There are a couple of ongoing studies with different design, so we need to wait maybe 1 more year to discuss this in an evidence-based manner. Yeah. So far, we are discussing individual experiences. Piotr Kalmutsky is asking, should we use DCB in the side branch before or after stenting? Thus, going through the stent struts will not harm DCB. I think he is completely right. This was not upfront decision to do DCB. You actually stented the circ as part of provisional, and then to avoid stenting the ostium of the LAD, you decided on treatment. So key is to predilate, prepare ostium of the LAD, and then deliver drug. And this is, of course, inevitable. Paclitaxel are crystals, so going through the struts creates stripping, but the size of those particles is relatively small, and we are really waiting for more experience to see.
It's a good comment.
It's a very good comment. And the final comment for your case from Muhammad Mazhar again, is there intraluminal hematoma along with dissection in that case, what should be your choice? But there is no hematoma, intraluminal.
But I think it was, as Stefan commented, a good result. So, and in our experience, but from the previous study with the predilation of the cyberarm, we consider type B acceptable.
And to conclude your case, you have clinical follow-up, which is very good. Patient is doing well, and you will perform only non-invasive testing.
I don't know. This case is relatively recent, so the patient is closely followed, and we will see what.
Your plan is to follow him non-invasively, just to answer the dilemma. So thank you very much, Manuel. Fantastic case. When I saw the first image with this calcified distal left main, I was sure this will not end up with DCB. Congratulations, excellent case.
Thank you.
Now I think we go to the future, and Stefan is one of the rare colleagues who has the opportunity to test new devices for physiology and application in multivessel PCI. Please show your case.
Thank you very much. Indeed, we are going, during the next couple of minutes, to discuss the benefit of FFR angio in bifurcations. During this session, I would like to explain you how to use these angiography-derived FFR softwares, and we have to understand how it works and how it can help you in bifurcation cases. It's a quite typical story that we very often have in our hospitals. He's a young patient. He has cardiovascular risk factors which are typical. Funny part of the story, the patient told us from the beginning that he recently was investigated for typical chest pain in another hospital. He had a coronary angiography showing a multivessel disease, and the patient was waiting for the phone call of his cardiologist because the cardiologist was discussing with the surgeon how to treat this patient, CABG or PCI. However, in between, the patient was admitted in our hospital with chest pain. It was a unstable angina because, as you can see, the troponins were low and stable. So I was waiting for something quite impressive given the discussion about surgery in this patient. This is, however, what we find. This is not what was expected. As you can see in the vessel that I will call the third marginal, there is a severe stenosis. In the LAD, honestly, there is a plaque in the proximal to mid part. It is quite a long plaque, but it's not very impressive. And I will show you the right, which is normal. So the first surprise is that for me, it was not at all an indication for surgery here.
Yeah, it's surprising that
So the first point, you saw that I started by injecting the left system where there were two stenoses, and then I changed the catheter to inject the right. Meanwhile, what could have been done during the right injection? Well, somebody in the cath lab, it can be a nurse, it can be a fellow, it can be one of your colleagues, could perform, because it's live, an FFR angio. How does it work? It's a technology based on routine angiograms. You need 3 different views. Of course, you need to be able on the different views to see the stenosis. You have to avoid overlap. Then the software, and it's extremely intuitive, extremely easy to use and very fast, will produce a 3D full tree and will do automatically the flow analysis. And what you will obtain on the right is this FFR angio color-coded map. It means that at every point of the left system, you can have the prediction of the fractional flow reserve, but you can also select the angulation that will help you to treat your patient, especially in bifurcation cases.
So can I stop you at this point? if I understand correctly, we have something that is color-coded map telling us about possible lesion with hemodynamic significance, and it's without wire, so no wire. It's strictly angiography-based, 3 projections. If I remember correctly, 10 frames per second should be the minimum.
Yes.
And then in 3 projections, you create color-coded map, which helps you make decision immediately on the table and proceed with procedure if you find significant lesion. Am I right?
Exactly, and if you think about it, it's very fast because otherwise you have to ask for a guiding, your team has to prepare the adenosine, you have to prepare the FFR wire, you have to prepare a lot of things. And here, after a few manipulations, you have the FFR in every vessel. So it's extremely interesting. Here we assessed, because it was, for me, the marginal was clearly significant, it was the culprit, but I was really interested about the LAD. And here in this patient, you can see that the LAD is significant, borderline significant, but still. And what you can see also, there is a nice plateau on the right side, meaning that after the initial plaque, there was nothing happening, but that the plaque that we saw is significant indeed.
Dr. Olusan is just asking, just to reiterate again the comment on different projections. Does this require 3 different angulations, 30 degrees apart, to assess the vessel?
Yes.
Okay.
There are different technologies available on the market. FRNGO needs 3.
3 projections. Okay, please continue. And you please continue asking questions.
So you might ask, well, it's a young patient.
Exactly.
You are deciding the LAD based on FRNGO. In our practice, when we have an FFRNGO value in the gray zone, very often we also...
What is the gray zone?
75 to 85.
So if you find 75 to 85, you have to individually make decision. And in this young patient, you decided to do wire-based assessment.
Yes, indeed. It's different from case to case. We published our group in Lausanne data showing that even in the gray zone, there was a very nice correlation. But here, come on, it's the LAD, it's a young patient, it can change everything.
Okay.
So the invasive FFR value was 77 invasively. FRNGO was right, and we knew that we had to do something on the left. So to summarize the case, he's admitted with chest pain. We have a clear culprit, which is the third marginal, and we have an invasive lesion on the LAD.
Okay. So diffuse pattern of atherosclerosis in the LAD, but definitely confirmed hemodynamic significance. And because of the haziness and really tight lesion in the circ, and its recent non-STEMI, you decided to treat culprit in this procedure and then to stage the LAD, just to help our colleagues follow the
And case. If there are some colleagues in the audience not convinced by the term marginal here, there's also on this FFR-NGO, we have the FFR value in the term marginal, which is significant. 74.
Also 74. Okay, fantastic.
So here, our decision was to treat the culprit, the third marginal, and we'll show you how we did, and then to perform the LAD in a stage procedure.
Good, good. I think we both agree. Manuel, you agree with this strategy?
Yes, totally,
okay.
Totally agree.
Let's see the angio and...
I will show you how to treat the marginal.
Yeah.
Well, our strategy was to treat the circumflex into the direction of the third marginal. This is an inverted provisional strategy, leaving a wire in the what I will call the distal circ.
Okay. Manuel, you will do the same, or?
Yes, I think this is a more difficult case for decision than the previous one.
Yeah.
Because you have the biggest and the more disease is easy, but you have the smaller, more disease at the osteum. So, but I think it's a good decision, no?
Yeah. Let's see how it went.
So we started with a very small balloon, 15 millimeters balloon. This is the results after the predilatation.
After predilatation, yeah.
Then we put a stent here. It was a 2.5 23 millimeter stent, and we performed POTS in the proximal parts using a 3.0 non-compliant balloon. And this is the results after the POTS. So I'm quite happy with the situation in third marginal, but now we have the dilemma. What do we do with these ostial parts after the stent in this bifurcation? Here again, one option is to repeat this FR angio, and this is what we did. And here the value was significant, and we took the decision to treat this vessel.
Yeah.
We repeat invasively, wanted to have a nice documentation, and here invasively it was also significant.
Yeah. If I can just have a comment. We wrote 2 years ago joint consensus document, European Bifurcation Club, Korean Bifurcation Club, with Bong Won-koo as the lead author, and Japanese Bifurcation Club on the role of physiology in bifurcation PCI. I think this is very important. You exactly follow the suggestions that we have made following stenting of the main vessel. If you have dilemma regarding the functional significance of the narrowing in the side branch, physiology is really a very reliable way to go, and you remove the plaque from the main vessel so you don't have contribution on the assessment. There is a criticism why not to use before the procedure FFR in the side branch, because the plaque in the main vessel impacts on the measurements in the side branch and contributes to false evaluation. But after stenting, this is exactly precise way to make decision regarding treatment versus no treatment. Yeah, please go.
The good news is also that if you want to measure it, you can do it using this technology.
Yeah, and you
don't have to change the wire.
You don't change the wire. You
cross
keep
the stent using a wire which is maybe
you
not
keep your wire which is jailed, and you assess, and then you make decision whether or not to treat.
Exactly. So the decision was to implant another stent. There are different options that maybe we can discuss later, and we decided to go for a culotte technique.
Okay.
After a strut predilatation, we implanted the second stent, did a pot with a 3.5, did a kiss, the final pot, and this is the final angio. And the beauty of this technology is that you can still check your result.
The final result.
And that the FFR was correct in this bifurcation.
Fantastic, bravo, excellent case. I mean, it's really wonderful to see new technology coming that can help us make proper decision. Several questions were sent by our colleagues. So first question from Dr. Rukas. Wouldn't be better to give regadenosine through a peripheral vein instead of intracoronary adenosine? You did not give adenosine at all.
No, you don't need adenosine for this angiography-derived FFR. Of course, for the invasive FFR, we have to give adenosine. There are plenty of options.
Exactly.
In this kind of scenario where you repeat a lot of FFR, I think a bolus makes the job. If you have to use a central line every time, it will take a lot of time. The patient will get symptomatic. Papaverine is also an option which is quite good.
Yes, and we are using more and more. Dr. Kavaya says FFR, okay, you did it, you agree. Bogdan Janusz is criticizing, as usual, thank you. Why not to image marginal and circ after first POBA to create proper strategy? It's a distal vessel, small vessels. I don't know if you would change the...
Well, we do have recommendations in a bifurcation decision about the use of FFR. I think this is an option. Well, I'm not against, of course, imaging. It could have been another option. Here the aim was to show these new technologies which are extremely useful. I think we have recommendations, we have evidence supporting this kind of...
So having physiological assessment is at least equally good following main vessel stenting to make indication. I forgot to ask the expert for side branch treatment, Manolo, what would you do different?
It's an excellent case, an excellent tool, because simplify the procedure and take the proper decision. My only concern in this case is the implantation of the second stent, because you can do a kissing after the main vessel implantation, or no, in this case, after the implantation toward the side branch, you can perform a kissing and evaluate when your tool, this is very easy, the result. If the result is good, the procedure has been finished.
Yeah.
So this is my only difference with the strategy.
To do after
proposed.
pot, kiss, and
No, even okay.
Yeah, pot, kiss, evaluate FFR, and then actually angio-FFR, and then make decision whether or not to use second stent.
It's an option. The tricky part is that the main vessel is also
two vessels of significant clinical relevance. Piotr has interesting question, Kalmutsky. Every time 3 injections, 30 degrees apart to assess. What about contrast volume with repeated angio-FFR? Do you remember the amount of contrast? Does it really...
No, I don't remember how much we gave. It's true that you have to select your patients. If you have a patient with a chronic kidney disease, maybe it is not the kind of patients you have to work on. Here, you remember the patient was extremely young.
Yes.
On one side, you give maybe much contrast, but you remember maybe what I told you at the beginning. This software also helps you to find the good projections in order to really open the bifurcation, to have good images. So when you use this software, you also gain information and you can also reduce a little bit contrast.
And it helps you select the optimal projection. Any trial, Dr. Kavaya has excellent question. Any trial comparing invasive FFR with angio-based FFR?
Of course, all of the softwares, almost all of them have been validated. FRangio is a fast FFR trial, which we published in Circulation a few years ago.
Yeah, Mario Araya, my close friend from Chile. Hello, Mario. Congratulations from Latin Bifurcation Club. I think this marginal is also very good case for drug-eluting balloon only, PCI, and bailout stenting in approximately 15% of cases. I think it's a good suggestion. Of course, we need to consider for small vessels. Dr. Atafon is asking, do angio-FFR can predict ostial left main lesion?
No. In this kind of softwares, you cannot assess the ostial left main stenosis because...
so not good for left main.
No, the presence of the
catheter. I think this is an important
itself.
message, yes. There was a question from Dr. Fatairi. Was the reverse tap better option than culotte with less layers of stents in these small vessels? If I can say maybe yes, maybe no. Depends on personal preference and the experience. With final kiss, final report, I think you achieve similar clinical outcome. I agree hypothetically that less overlap in the main vessel may hypothetically decrease potential risk of future adverse events, but we don't have data. It's based on individual cases. And Dr. Mashar is asking you, Stefan, what are your final recommendations to use angio-FFR in the setting of bifurcations, I guess, if you summarize globally, not just this case?
I think this is the perfect candidate for the use of this technology. You have a bifurcation, you know from the beginning that you have to treat it, but you have also another vessel, here the LAD. Using 3 projections, you can assess all the stenosis. It's perfect. You don't need extra contrast to assess the LAD. Then I think if you have a single vessel disease or just the bifurcation, this is also something extremely interesting. Country by country, there is a question of price, of reimbursement. And well, depending on how the technique and what's the price in the country, it can be a very, very interesting option.
Yeah, but I'm sure, you know, with time, every new technology has the cost, the issue, and then with time, depending on the acceptance, of course, there will be solution. I like, to be honest, very much the idea to use this software to assess side branch after main vessel stenting and optimization. Really gives you exact value or range to decide whether you need to go or you can stop procedure, because we try to promote proximal optimization as a mandatory step, and then after POT individually consider. This is, I think, good point to use it here.
Fully agree.
So I agree with your comment.
And the take-home messages here is that angiography-derived FFR works. It helps you and also in bifurcations. Thank you.
Okay, thank you. Great. So we are at the end of this very interesting webinar. I enjoyed personally very much. It was really fantastic. Two technologies that I really like, and I like to have more data. I'm sure that this discussion helped people better discuss indications and potential use. We discussed really the role of DCB based on the current available evidence and the way to do it. And we discussed also interesting future indications for angio-FFR, also in bifurcation treatment, and we are really waiting for more publications and broader use. So I would like to thank you both. You were fantastic as always. Thank you, Manolo. Thank you, Stefan. And I would like to invite our colleagues for the last Bifurcation Continuum webinar in this season. It's planned on March 26th with fantastic Pedro Gonçalves and Jens Lassen, two excellent colleagues and friends. And I think one of the topics that is personally my preference for this year, Visible Heart Lab with Polya Iso and the team. And we will see how to use virtual model, big heart, which is perfused, defibrillated, and with angioscopy, you can perform stenting with direct assessment with angioscopy, OCT, and you can really understand how to correctly perform bifurcation stenting and discuss potential pitfalls at each step of provisional and two stents, and learn how to prevent and manage complication. I was the one who did the cases before TCT. It was really fantastic experience for me, and I'm really looking forward to share it with you, and I invite you to register. Thank you very much and have a good day.